All right, so as you can tell, today's kind of like a hodgepodge of breast topics. We're going to kind of bounce around as if maybe like you were in clinical practice, you would see different patients here and there, so there's no particular order to things. But first part of this topic is gynecomastia. Dr. McLaughlin, she's the most senior of the breast surgeons at Florida. I have to give thanks to her because she sent me a lot of these slides, and there hasn't really been too much in the way of gynecomastia updates, so a lot of this is more of a review than an update. But as you probably know, the incidence of this spans 3 different parts of your lifetime. So when you're a baby, then puberty, and then when you get older. And most of the patients are asymptomatic. In fact, most of the patients, true story, when I was an adolescent, I felt kind of like this nodule underneath the right nipple area. I had no idea what it was. And like 2 years later, it went away, or a year or so, went away. I never sought any treatment for it. So the majority of patients, 90% of the patients, are totally fine. The ones who do get worried about it and seek treatment for it tend to be the patients who have the drug-induced medications or illegal medications or prescribed medications, which we'll talk about. It's part of your MOC. Those that are persistent after puberty, and then those that are idiopathic, where you always have to keep in the back of your mind, could these patients have male breast cancer? So for most patients, the gynecomastia is happening because of an imbalance of hormones. Either there's too much estrogen or not enough testosterone, or some change in the metabolism of those hormones based on medications you're taking. And history and physical is very key to try to determine if this is something you have to worry about versus something not. This is just looking more into the different sorts of hormone imbalances and all of the different etiologies that can come about. I think, to be honest, probably you're not going to end up working all of this up. Usually it's the primary care physician who's working all of this stuff for us. But this is just to have kind of a reference to see, just to make sure when you see a patient that these things have been worked up and considered. So these are the main medications. The ones that are circled are the ones that are most related to gynecomastia, so different steroids. So, people who abuse anabolic steroids for muscle mass building, they can have gynecomastia, different types of antibiotics, and H2 blockers and digoxin. So these are the ones that are highlighted that have the strongest association historically with gynecomastia. So gynecomastia is really a mass. So underneath the nipple areolar complex, you can feel sort of a hard, firm mass that's palpable. It can be unilateral or bilateral. It can be a rubbery mass. So the physical exam is very key, because if it's away from the nipple areolar complex, that's a little more concerning. If you had a mass in a different quadrant of